I'm going to give you a little bit of background first, and then we will go in detail to our results. So PSMA PET-CT or PSMA-targeted PET-CT or prostate-specific membrane antigen-targeted PET-CT is a novel imaging technique that has showed superior accuracy in detecting prostate cancer lesions compared to conventional imaging, which is CT and bone scan. The results of a randomized multicenter trial from Australia showed a 27% superior detection rate and accuracy in detecting metastatic disease in patients with primary prostate cancer compared to conventional imaging. Even more than that, the FDA approved PSMA PET-CT in the US for 2 indications: patients with high-risk prostate cancer and in patients with biochemical recurrence in December at UCLA and UCSF. And even more exciting, just recently, last week, FDA approved a second PSMA PET-CT ligand for patients with prostate cancer for the same indications. So despite all these steps are very exciting, and it's so important to have a new imaging technique, a new imaging tool, which has superior diagnostic accuracy. Imaging goes beyond that and can be used also for treatment monitoring in prostate cancer. And the literature on the prognostic role of PSMA PET for treatment monitoring is rather scarce. There's literally no evidence showing or at least investigating whether PSMA PET can be used to tell us whether a treatment should be stopped or if a patient is responding or not to a prostate cancer treatment. Even more than that, there is no standardized response evaluation criteria on how to assess PSMA PET-CT. And this is why we did the study. This is why we initiated this multicenter study that included 124 patients with prostate cancer that were treated with lutetium PSMA therapy and received a PSMA PET-CT baseline before the treatment and after 2 cycles of treatment. The study had 3 key objectives. The first one was to evaluate the prognostic value of PSMA PET for overall survival in patients treated with lutetium PSMA treatment. The second one was to establish response evaluation criteria using clinical data and provide further guidance on how to assess the scans. And the third one was to see whether there's an added value in using PSMA PET on top of PSA values or prostate-specific antigen to evaluate response to the treatment. PSA, as we know, is the current standard of assessing whether a patient is responding or not to the treatment. And what we found is really exciting and is very encouraging. When analyzing these pairs of baseline and PSMA and follow-up PSMA PET after 2 cycles, or at interim, we call it interim PSMA PET, we show that changes between these two scans were prognostic for overall survival. And also, I'm going to tell you how we did assess the scans. We looked first whether patients have a new lesions or not, for the second scan. And also, we looked at the overall tumor burden, how it changed, whether it decreased or whether it increased. And then after we found that both appearance of new lesions on the scan and also changes in tumor burden on the scan are prognostic for survival, we combine these 2 parameters and we developed RECIP, which stands again for Response Evaluation Criteria in PSMA Imaging. We found that patients who have no new lesions on the second scan and a response, a significant decrease in changes in tumor burden, they are classified as partial responders. Patients who have at least 1 new lesions on the scan, on the interim PET, and an increase in change in tumor burden, they are considered progressors or having progressive disease. Patients that do not qualify for neither responders or progressors, they were assessed as having stable disease. This includes patients who have increase in tumor burden, but no new lesions, or for instance, a decrease in the overall tumor burden, but one new lesions. So this criteria really help us to differentiate between true responders or true progressors or patients who have a mixed response. We were able, when classifying the patients at interim, using these criteria, like real progressors, real responders, and patients with mixed response, these three categories had a significant different overall survival, which showed us that that RECIST can be used to classify patients and predict overall survival. And regarding the third key objective, also this is very interesting, and especially for not only for nuclear medicine, but especially for oncologists, for uro-oncologists, this is really important because we found that we had three classification methods. One was the PSMA PET itself, the PSA itself, and then a composite classification method, which combine the PSA and the response in PSA and in PSMA PET CT. More in detail, patients who had a response in either PSMA PET CT according to RECIST or in PSA according to PCWG3 criteria were classified as responders. Or any patients who had a progression in PSA according to PCWG3 criteria or in PSMA PET CT according to RECIST were classified as progressors. And what we found is that the combined classification method had a superior prognostic accuracy compared to PSA alone. So this tells us that yes, PSMA PET is prognostic. Yes, we have some criteria to assess response in PSMA PET. And yes, we can use PSMA PET combined with PSA to classify the response, to assign to see whether the patients are real responding or not. This can really have clinical implications also for clinical trial design. When we use the composite classification method, we can use it as an efficacy endpoint, meaning we will not assess the response only by PSA, but by PSMA PET CT and PSA. So we will identify more patients who are responding to the treatment. And then we need overall, when we design the clinical trial, we need overall less patients to be included in the trial, which decrease economical burden, avoid possible unnecessary side effects for patients who would have been involved there, and also make the outcome of the clinical trial more rapidly available for the public. To sum up, yes, PSMA PET can be used for treatment monitoring, but this was a retrospective study, therefore the level of evidence is limited. And to move this forward and really provide high level of evidence that PSMA can be used, we need a clinical trial to validate and confirm these findings. And even more than that, ideally, we would have a randomized trial where we compare the prognostic role of PSMA PET CT compared to conventional imaging for response evaluation in prostate cancer therapies. It can include not only lutetium PSMA like we did in this trial, but other prostate cancer treatments like chemotherapy, androgen signaling inhibitors. Such a positive outcome of such a randomized trial would enable replacement of conventional imaging, not only in the diagnostic side, but also for treatment monitoring in prostate cancer.